Good morning. I am Dr. Mulasheri Ajit Shankar Das, Director of STEMI India in the Chest Pain Clinics. My talk today is the optimal management of post-myocardial infarction patients in a thrombolytic center or in a small hospital. So we should understand that myocardial infarction is a dangerous disease and the mortality first year average is 10%. That means 1 in 10 people will die after myocardial infarction. Subsequently, every year there is a 5% mortality and 85% due to coronary disease are sudden, of which 50% are sudden, 50% within the first 3 months and 33% within the first week. So the important thing is we have to remember it's a dangerous disease and you should clearly watch the first 3 weeks because that's where the highest mortality happens after the first hour of a myocardial infarction. So as you can see, the mortality has dropped significantly from 1967, where almost 1 in 4 to 1 in 5 patients would die after myocardial infarction, to now, in 1999, it's close to about 6%, and if you look at today, it's close to less than 5%. Patients will die at 25 to 30 days post-myocardial infarction. And this is because of the development of coronary care, the development of beta blocker, the development of various thrombolytic agents and aspirin, and improvements in technology, fibrin-specific lytis, and obviously primary PCI. They are all improving the mortality after myocardial infarction. So the risk stratification is based on history, clinical findings, ECG, lab tests like troponin, whether they peak and fall quickly, non-invasive tests like ejection fraction on echo. As you know, a low EF of less than 40% is a predictor of mortality. Residual ischemia, if you've not revascularized the vessels properly, you will land up with ischemic problems. And then a cardiac catheterization. And if there's a rhythm issue, an electrophysiology and ICD requirement if patients have a risk of sudden cardiac death. So LV function is one of the most important determinant of prognosis, and that is why we need to do early reperfusion. For example, if your EF is better, your mortality is lower. Your EF is poor, like say 15 to 20%, then your mortality at 1 year is close to 50%. So it's very important to maintain ejection fraction in patients who have post-myocardial infarction. How do you do that? One, you risk stratify the patients. What are the pre-infarction characteristics which will show that the mortality will go up? An elderly age, old myocardial infarction on which there is a fresh myocardial infarction, female gender, hypertension, history of congestive failure, bad lipids, diabetes, especially if you are say a ketoacidotic at the time of the myocardial infarction is a very bad sign. And as we know, the South Asian group has higher mortality, the black race has higher mortality than the Caucasian races. And certain clinical criteria of heart failure, Philip class 4 or shock will predict patients will get into trouble. There are ECG criteria, chest X-ray criteria, for example, ECG, if you have a large anterior MI, RBBB, that's a bad sign. Chest X-ray shows cardiomegaly, pulmonary venous congestion, and venous hypertension is a bad sign. Markedly elevated cardiac enzymes and troponins which don't come down quickly is a bad sign. Elevated kidney function means low cardiac output and a cardiorenal syndrome, and hemodynamic criteria with low cardiac output is a sign of problems. Complications of MI like ventricular septal rupture, a papillary muscle dysfunction with MR, and a myocardial rupture shows